Hello and welcome to this video recording of a presentation that was originally meant to be given in October 2021 to the Warwick Clinical Skills Society. So to the Warwick students watching this, my apologies, this is slightly different to the presentation you actually got given because I made a mistake and thought I was talking about blood pressure, vital signs and BMI. I was actually supposed to be talking about blood pressure, infection control and BMI. However, I'd already prepared this presentation, so I thought I'd record it for you, and then you've got more information available to you anyway. So, as I said, we're going to talk about these three things: blood pressure, taking vital signs, and recording the BMI. And we're going to start with blood pressure. And if you were here, I'd be asking you, we've got machines that do this now, why do I need to know how to take a manual blood pressure? And maybe you'd say something along the lines of, we may not have the machine in the first place. I mean, that certainly happened to me when I was on a GP placement once. I was seeing a patient with my clinical partner and there was no Dynamap in the room for us to use, so we took a blood pressure manually instead. In case you're interested to know, Dynamap isn't actually a brand name as I thought, it's actually an acronym. So, random fact for you there. A second reason is that you may actually have to take a manual blood pressure sometimes. So, the machine may struggle to get a blood pressure for some patients, maybe those with atrial fibrillation and irregular heartbeats. So that's something you might have to come and manually take it yourself. Also, particularly very high blood pressures will also require a manual blood pressure because the machine won't go up that high or won't be as accurate at very high blood pressures. And the third reason, which I feel is a bit of a bad reason to want to learn to do anything, is you need to know it for exams. So how do we go about doing that? Well, this is an interaction with the patient. So we're going to want to start off by wiping. So washing our hands, introducing ourselves, getting the patient to identify themselves, and then explaining the procedure and getting consent. So I might go and wash my hands and put on my PPE and say, "Hi, my name is Jonathan Looms of Radial. I'm a final year medical student. Can I take a name and date of birth, please?" They'll say, give us that information, and then I'll say, "I've been asked to take your blood pressure today. Have you had that done before?" They'll probably humour you and say no, and then you'll say, "Okay, well, basically involves putting a cuff around your arm. I'm going to inflate it a couple of times, and I'm going to then have a bit of a listen to the pulse in your arm to try and determine your blood pressure. It could be uncomfortable, but it shouldn't be painful. Are you happy to continue?" Then we're going to want to place the cuff. Before placing the cuff as well, you're going to want to point out to the examiner that the patient's been sat for ideally sort of 5 minutes and rested, rather than doing it when they've just sat down in the room. So just make a point of mentioning that to the examiner. You also want to make sure that the patient's arm is at about heart level and it's resting. You don't want them tensing up their own arms to support their arm. You want them relaxing the blood pressure. Relaxing their arm so you're getting accurate reading. You also might want to offer the patient the choice: do you have a preferred arm? Or you sometimes might not have a choice. So if a patient's had a mastectomy, you won't be able to take the blood pressure in the same side as the mastectomy, so you're going to want to use the opposite side instead. And there can often sometimes be a little bit of difference between left and right arm blood pressures as well. So you might want to try and keep the blood pressure in the same arm. You're going to inflate the cuff 2 times. The first time you inflate it, you're going to palpate the radial pulse. And just feel for it when it disappears. So I typically might inflate it to 120 first of all. If I can still feel the pulse, I'll increase the pressure. If I can't, I'll decrease the pressure until I can feel it again. That's going to give you an estimated systolic blood pressure. However, you then want to totally deflate the balloon or the bladder and then re-inflate it. And you're going to re-inflate it to 30 millimeters of mercury above the estimated systolic blood pressure from the radial pulse. And then placing your stethoscope above the brachial artery, you're going to want to feel or listen for characteristic sounds as you slowly deflate the cuff at about 2 or 3 millimeters of mercury per second. And you can record the blood pressure to the nearest even number. The machines can record it more accurately to odd numbers as well, but as we're doing it manually, we stick to even numbers. So, first of all, what size cuff? We want to make sure the cuff covers, or the bladder of the cuff covers 80 to 100% of the patient's arm. And if you look inside the cuff, there'll be a little index measurement where you want the edge of the cuff to sit within. So have a look at a blood pressure cuff yourself and work out where that line should be, and hopefully when you put it in the patient, that your line should fall within those index markings. If the cuff is too big, so you're going to underestimate the pulse, and if your cuff is too small, you're going to end up overestimating the blood pressure instead. And where do you place the cuff? So here's a photo of my left arm, and if you feel your own arm as well, you'll feel there are two knobbly bits on the side of your elbow. Those are the medial and lateral epicondyles. And you want to try and palpate and feel for the brachial pulse, which is the one that we use for measuring blood pressure, about a third of the way in from the medial epicondyle. You want to maybe use your thumb or 2 or 3 fingers, and you might have to push a bit deep to try and feel the pulse. Some pulses are easier to feel than others. A good landmark for this is the biceps tendon, so you can feel that as well, and then sort of palpate near there for the pulse. And once you've found the pulse, you want to place your cuff approximately 2 centimetres proximal. That's 2 centimetres further up the arm than where you can feel the pulse. And where you feel the pulse is where you're going to be placing your stethoscope when it comes to auscultating. Also remember that on the blood pressure cuff itself, you're going to see some arrows on the cuff telling you where the artery is. So you want to make sure those arrows are lined up with where the patient's brachial artery is to make sure you've got the maximum compression on the artery. So after we've placed the cuff and we've inflated this and listening to the stethoscope, we're listening for some characteristic sounds. So this is Korotkoff, surgeon from Russia, I think. He described these sounds that you hear when you listen to the brachial pulse as you deflate the cuff. Personally, probably due to lack of experience, I don't always hear all these distinct noises, but for our purposes it's not too important. As long as we can hear the first sort of very, very clear thuds, that gives us our systolic blood pressure as soon as we start hearing those. And then as soon as the final sounds start to disappear, that's going to be our diastolic blood pressure. So as soon as you can't hear any sounds anymore, that becomes your diastolic pressure. As I said, we record these to nearest an even number. It's also pretty worthwhile just talking about what constitutes a normal blood pressure. So if you've done your SOC Pop lectures by now, you'll realise that normal is a subjective term and means different things in different situations. But we're probably looking for, in a healthy adult, for a blood pressure less than 120/80. So it's less than that, we're happy. There are sort of low risk of developing complications from high blood pressure. Anything above 120/80, we start to get a little bit concerned that they could be hypertensive, but our real cutoff for doing something about it is 140/90. There's also something called white coat syndrome. So patients, when they come into a clinic, so a GP or hospital, they might be a little bit anxious themselves already, and that can sometimes push the blood pressure a little bit over 140, and we might start thinking about giving them medication. So before we do that, we often send the patients home and tell them to go and buy a blood pressure monitor themselves and see what their blood pressure is doing at home when they're not in a clinical environment. And then if it's less than 135/85, we're a bit happier. However, being hypotensive, having too low blood pressure, is also a concern, particularly very acutely as well. So we start thinking that anything less than a systolic blood pressure of 100 could be a sign of hemodynamic instability, So we might want to take actions there depending on the clinical situation. And there are also some criteria for scoring risk or determining management that use a blood pressure of 90 systolic or 60 diastolic as a cutoff or as a score for determining higher risk patients as well. However, with blood pressure and with vital signs, don't always rely on a single reading depending on the situation. Individual patients vary, so they'll have their own variability. So for instance, a highly trained athlete may have a systolic blood pressure of less than 90. And equally, trends in blood pressure and in other vital signs can be just as illuminating as a single one-off test. So are they increasing over time, in which case you might want to address that. Are they decreasing over time, which could be a sign that maybe either their blood pressure is improving or they're becoming sicker. So all these things will become materialise for you as you do more than medical course. I would say for the time being, you want to see patients with a blood pressure less than 120 over 80, and if they're more than 140 over 90, you want to sort of be concerned about the complications of hypertension. So that's a quick run through blood pressure. So now quickly coming on to vital signs. And if you're taking vital signs, your patient is probably hot, or cold, or just unwell, or you're just monitoring them. But probably hot is a little bit of a mnemonic that might work for you. It stands for pulse, respirate, oxygen sats, blood pressure and temperature. These are all factors that you will do as part of an A2E assessment. So if you're in second, third and fourth year, or as a doctor visiting a sick patient, the first thing we might consider doing is an A2E assessment, and that includes taking all of these particular measurements. So I've put pulse and respirate together because I would recommend taking these at the same time in inverted commas. So in an ideal world, you take pulse for 1 minute, and similarly, respirate I take for a minute, and the number of chest movements you see in that minute is the respirate. However, you can probably get away with doing the pulse for 15 seconds and timesing by 4, and the respirate for 30 seconds and timesing by 2. And why that's how I do these together is because I would take the pulse, and after I finish taking the pulse, I would continue holding the patient's wrist, pretending while I'm taking the pulse, while I'm actually looking at their respirate. It's always really important as well to make sure that the patient isn't talking at this when you're doing these vital signs, because it can upset it. And also patients, if they know you're looking at their chest, or if you know that they're looking at them, they may start doing weird things with their breathing and become more conscious of it, and that will change their respirate and things like that. Another skill that sometimes I've heard respiratory nurses do is they'll take the pulse and put the patient's arm against their patient's chest, and so they can feel the chest move at the same time as feeling the pulse. And for the pulse, we're taking rate and rhythm and character and volume. Then you can move on to take oxygen sats and temperature as well. Perhaps put the oxygen sats probe on their finger, and while it's taking a reading, just go and get the tympanic thermometer and take a temperature reading at the same time. And then you can do the blood pressure as we've just described there. And these readings can all get recorded on a News 2 chart. That's what the nursing staff will use for monitoring a patient's general well-being and sort of flagging up any potential concerns. A few things to note about doing vital signs in a clinical or OSCE setting. It's still a clinical encounter, so you don't want to forget to wipe. So wash your hand, introduce yourself, identify the patient, and explain what you want to do. Also, for every other clinical exam you will do, you will want to do an end of bed inspection. So in an exam setting, exam scenario for taking vital signs, I might suggest that you do an end of bed inspection at the very start of it anyway, and comment on how alert the patient is, because at least in the Warwick Pro form, it doesn't include AVPU as part of vital signs. APU, which stands for alertness, or are they alert, are they respond to voice, do they respond to pain, or are they unconscious or unresponsive, is something you'd also record on the News 2 chart. And it could just give you an extra bit of credit with the examiner for seeing the patient as a whole, not just going through the motions of just doing the vital signs. So you could say, from end of bed inspection, the patient is sat out, they seem comfortable at rest, and they are alert. And at the end of the, say, if it was in an OSCE setting, you'd also offer to do urine output and blood glucose. I'd always be prepared, though, to ask why you might want to do urine output and blood glucose. So perhaps the patient is query sepsis, and so you want to monitor urine output to make sure that their kidneys are still functioning. And blood glucose measurements, maybe the patient is diabetic, so you want to monitor their blood glucose as part of their normal package of care. Perhaps they're on steroids. Steroids can cause you to go hyperglycemic, so you want to monitor blood glucose for that reason. Or thirdly, perhaps the patient seems a little bit confused and drowsy, so you might want to do blood glucose to make sure they are not hypoglycemic, and then fix that. So the only thing I'm going to talk about these is the pulse. And we assess both rate and rhythm and character and volume. So rate and rhythm is taken from the radial pulse. That's the pulse we palpated when we were feeling for the first inflation of the cuff and the blood pressure. And the landmark for this is the flexor carpi radialis. You'll learn more about this when you do block 4 at Warwick. But flexor, because it flexes the wrist, the carpi, and it's nearest the radial, or the radius, another one of the bones in the forearm. So flexor carpi radialis. So you want to sort of palpate around there, 2 or 3 fingers, feeling for the pulse. And you're going to count that for 15 seconds and then times by 4. But you also want to comment on the character and volume. So that can be done by feeling for the brachial pulse. That's the one near the elbow that we use for the blood pressure, or the carotid pulse. And the carotid pulse can be felt in the neck. And the good landmark for this is the thyroid cartilage. So like where the underside of the chin meets the neck, just underneath there you'll feel a slightly harder bit of tissue. That's your thyroid cartilage. And if you sort of take your fingers and then move laterally and posteriorly, you should be able to sort of feel the carotid pulse in the neck. Really important thing about taking the carotid pulse is you don't want to feel both pulses at the same time, because you could reduce the blood supply to the brain, which wouldn't be too good for the patient. Also, you don't want to take the carotid pulse if you're querying stroke. And character and volume as well, things you might comment on. Normally you'd say normal character and volume, but if a patient was particularly sick and they were septic, the character of the volume may be bounding. So there's less resistance in the arteries, so you feel the full force of the heart when you palpate the pulse. That would be called a bounding pulse. Similarly, or conversely, the pulse could feel thready if the patient is hypovolemic. So maybe they've had a hemorrhage or an internal bleed. There's less blood circulating in the body, so you can't really feel a very strong pulse there at all. So those are the key things to take away from vital signs. So we finally move on to the BMI, the body mass index, which is a rudimentary tool to help us calculate health risks. We calculate it by taking the weight and dividing that by the height squared, the weight in kilograms and the height in meters. To measure the height, we use a stadiometer, and we'll get the patient to put their heels against the back of the stadiometer, and we also want their buttocks and their shoulders to be touching the stadiometer as well. For both the weight and the height, the patient is not wearing shoes. Patients who are bedbound, you can then estimate the height using the ulnar length. So the ulnar is a bone in the forearm. You can measure that and then take information like the patient's age and gender and put that into a chart, and it will return you an estimated height, which you can then plug into the formula. And then we take the result of the BMI and we can see where it falls on this scale. And ideally we want it to be between 18.5 and 25, which constitutes a healthy, in inverted commas, or a normal BMI. Below this, we consider them to be underweight, and above this, we consider them to be overweight. And above 30, we consider them to be obese. And there are various categories of obesity depending on how far above 30 they are. However, these values were taken based mainly on data from white Europeans, and it seems that the health risks associated or identified via the BMI are a little bit different for ethnic minorities. So NICE recommends that Asians and Black African and Afro-Caribbean patients use a slightly modified scale to determine their risk. And so if it's between 23 and 27.5, they are at an increased risk, and more than 27.5, they are at a higher risk. And we say a risk of developing conditions, maybe like high blood pressure, type 2 diabetes, perhaps risk of cardiovascular problems in the future as well. I used to think that 23 to 27.5 was the category for being overweight for ethnic minorities, and above 27.5 was obesity. However, the NICE guidelines don't use that specific language. They talk about them having an increased risk and a higher risk, not being a new categorization for overweight and obesity. But hopefully that's all made sense. I hope you've enjoyed listening to the presentation. If you've got any questions, you can email me, and I'll put a link to the little test that we designed just to cover some of these points in the description below. Thank you very much for listening.